Good afternoon, everyone. Let me introduce my PhD thesis, which is the impact of triglyceride level on the risk and outcome of different diseases. My name is Luca Havelda, and I work as a clinical dietitian at the Institute of Pancreatic Diseases. My vision is to contribute to the prevention of diseases in association with hypertriglyceridemia, and therefore my mission is to provide evidence-based and valuable data in this process. To reach my mission, I have two specific goals. Both of them are investigating the effect of different triglyceride levels, the second one on the outcome of COVID-19, and the first one on the development of diabetes mellitus. This first project is a systematic review and meta-analysis, and we started this project last September. The prevalence of type 2 diabetes mellitus more than doubled in the last 20 years, and according to the literature, more than 90% of these type 2 diabetes mellitus cases are preventable among men if the risk factors are eliminated in time. Hypertriglyceridemia can be a potential but modifiable risk factor of diabetes mellitus, and although the association between these two diseases is highly investigated, how the different triglyceride level affect the development of diabetes mellitus, or whether there is a dose dependency, is still not clear. Based on the guidelines, triglyceride level fell into three main categories. This is the normal, the borderline, and the high. The relationship between these two diseases is also quite important, given that hypertriglyceridemia has also a really high prevalence rate. It can affect almost 1/3 of the population. Therefore, our aim was to investigate the dose-dependent effect of hypertriglyceridemia on the development of diabetes mellitus. Our question was, does hypertriglyceridemia dose-dependently contribute to the development of diabetes mellitus? We have investigated adult population with different triglyceride level, and our outcome of interest was the development of diabetes mellitus. According to our hypothesis, hypertriglyceridemia is a dose-dependent risk factor of diabetes mellitus. We have conducted our systematic search in three main databases, and after the duplication removal, we were left with more than 21,000 articles. After the careful selection process, we have included 135 articles, and with the help of the reference chaser, we have found 11 more eligible articles. As I earlier mentioned, the outcome of interest was the development of diabetes mellitus, and it is really great that we are going to be able to analyze more triglyceride-related factors, such as triglyceride glucose index, triglyceride to HDL cholesterol ratio, or the hypertriglyceridemic waist phenotype. But currently, I have my finished analysis on the different triglyceride levels, so let me show you my forest plots. My first forest plot shows the hazard ratio of incidence of diabetes to those who had hypertriglyceridemia at baseline compared with those who did not have hypertriglyceridemia. In this case, we were able to include 8 follow-up cohort studies, and the pooled hazard ratio was 1.73, which means that there was a 73% higher chance of developing diabetes mellitus to those who had hypertriglyceridemia in baseline, which means that the triglyceride level was above 1.37 millimole per liter. The heterogeneity was quite high, which is coming from the differences in the population, and it was a statistically significant and clinically relevant result, and it suggests that hypertriglyceridemia can be a risk factor of diabetes mellitus. But we were curious about the dose dependency, so we have investigated it further with different cutoff values of the triglyceride level. In my following two forest plots, I will show you the differences between those who had the borderline triglyceride level at baseline and those who had the high triglyceride level at baseline. In the first case, the patient has borderline triglyceride level, and in this case, the hazard ratio was 1.42, which means that there was a 42% higher chance of developing diabetes mellitus to those who had the borderline triglyceride level compared with those who did not have hypertriglyceridemia. And we have found an even higher hazard ratio for those who had the high triglyceride level. In this case, the pooled hazard ratio was 1.84, which means that there was an 84% higher chance of developing diabetes mellitus. In these two cases, we were able to include three follow-up cohort studies with a total population number of almost 30,000. And my last forest plot shows the mean differences in the baseline triglyceride level. for those who had developed diabetes mellitus during the follow-up compared with those who did not develop diabetes mellitus. In this case, the heterogeneity is also quite high, but it is not surprising because we were able to include 57 studies here, so there are a lot of different populations in this case, and the pool's mean differences was 0.46, means that those who developed diabetes mellitus during the follow-up had almost half millimole per liter higher triglyceride level in baseline. The strength of our research is the transparent methodology, the large patient numbers, and that we are going to be able to analyze different triglyceride-related indexes, and the limitation is the heterogeneity, and that we are going to include retrospective studies as well. As a conclusion, according to these results, we can say that hypertriglyceridemia may be a dose-dependent risk factor of diabetes mellitus. Its implication for practice is to be able to schedule the most optimal follow-up visits according to the predictive risk of diabetes mellitus, and also, of course, the patient education on how to prevent diabetes and hypertriglyceridemia. Its implication for research is to find the most effective lifestyle strategy and to be able to investigate maybe within a normal range the different triglyceride level effects on the development of diabetes mellitus. Here you can see my progress so far. Currently I am writing my manuscript while I'm still waiting for the other results. My second project is investigating the effect of different triglyceride levels, but on the outcome of COVID-19 disease in this case. It is going to be a registry analysis. From 2019, COVID affected millions of people all over the world, and the outcome was influenced by many factors, which should be identified to be able to interfere as soon as possible or do early intervention when needed. As I earlier mentioned, the prevalence of hypertriglyceridemia is quite high, and according to the latest studies, it was associated with inpatient mortality. However, the association between the different triglyceride level and the outcome of COVID-19 is still not clear. Therefore, our aim is to investigate the dose-dependent effect of hypertriglyceridemia on the outcome of COVID-19. Our question in this case, does hypertriglyceridemia dose-dependently worsen the outcome of COVID-19? In this case, we are going to include adult patients with COVID diagnosis with different triglyceride level, and our outcome of interest is mortality, the rate of intensive care unit admission, need for mechanical ventilation, severity, and the length of hospital stay. According to our hypothesis, hypertriglyceridemia is associated with worsened outcome of COVID-19 dose-dependently. With this information, we would like to aim a better patient care with knowing the predictive severity of this disease. For this research, we are going to use the coronavirus registry created by Catalog Study Group, which has a total patient number of more than 1,000 positive cases. Currently, we are working on cleaning the data table. And as you can see, from 1,000 adult cases, we only have the triglyceride level for around 300 patients. But fortunately, we have biobank samples, and after additional measurements in September, we are going to be able to analyze more than 500 cases. As a summary, I have 2 ongoing projects, and hopefully we are going to submit the first one this year. Thank you for your attention, and always remember Hippocrates' wise word, leave your drugs in the chemist's booth if you can cure the patient with food. Thank you.
Congratulations for the very nice presentation. Question, please.
Thank you for your presentation, Luca. My question is regarding for your first topic. So, do you have any data about that? What was the average time between the diagnosed hypertriglyceridemia and the onset of the diabetes?
Thank
mellitus?
you. Thank you for the. Okay.
Well, so as I saw that you analyzed 3 different levels of triglyceride levels. So which was the worst? So which was the so do you make any comparison or any subgroup analysis regarding the triglyceride level, and the diabetes mellitus?
Okay, so
for
for
the
the
incidence
first
of
question,
diabetes
yeah.
mellitus.
So for the first question, unfortunately, we do not really know the time of the of the development of the diabetes mellitus. They were follow-up cohort studies, and we only know that at the beginning they did not have diabetes mellitus, and after 5 years or 10 years, they developed the diabetes mellitus, and we are investigating the baseline triglyceride levels. So in these cases, the hypertriglyceridemia was there at baseline. And regarding your second question, unfortunately, we are not going to be able to compare like high triglyceride level with borderline high triglyceride level, because we do not really have a data on that. We only have the data like how the borderline triglyceride level is compared with to those who did not have hypertriglyceridemia and therefore have the high triglyceride level affect the development of diabetes mellitus compared with those who did not have hypertriglyceridemia. So we only can have these kind of results with what have I shown, unfortunately.
Thank you.
Thank you.
Okay,
Just one more question.
There are some other questions also. Okay. There was another question over there. Yes, please.
Yes, still regarding the first presentation, is there any intervention made during the follow-up for the patients with high triglyceride levels, for example?
Thank you for your question. It's a really great question. In these cases, when they have used fibrate or statins, we try to exclude those, but because they were like population-based cohort studies, not each case is registered, whether they were on medications. So as far as I see, I won't be able to do a subgroup analysis, because we plan to do a subgroup analysis whether they had medication or not, but in a lot of cases it is not reported. So it's a huge limitation.
Yes, that is a great aspect. And one more question. You divided the triglyceride level in 3 groups.
Yes.
But regarding the diabetes mellitus, is there no diabetes and diabetes? Is there any information about, for example, impaired fasting glucose levels? Yes.
Yes, thank you. There are some cases when they examined whether they developed prediabetes, but we only be able to include it to the systematic part, not the meta-analysis, because we do not have that much data that can be pulled together. And another limitation, which I think it's important to mention here, that most of the studies did not exclude prediabetes. We really hope that we will find a lot of studies that exclude prediabetes at the baseline, but most of them not excluding it, but hopefully we are going to be able to do subgroup analysis. Thank you.
Okay, one more question.
A question, what do you think hypertriglyceridemia is really a risk factor or the consequence of diabetes or a comorbidity?
Thank you for the question. In my last progress report, someone said that it is like a chicken egg question, which is, I think, a really great sentence for it. I think, of course, we know that for those who have diabetes, they can have elevated triglyceride level and dyslipidemia. So we can know that it can be a comorbidity of diabetes mellitus. But I think that from these aspects, they usually not investigating it, and it can be, I think, a really great information for us when we screening patient, because insulin resistance can cause, of course, again, hypertriglyceridemia, but insulin is not always checked in like yearly screenings. And if we can say that, okay, there is an elevated triglyceride level, maybe we should go forward and check the insulin, maybe they have something or regarding the glucose metabolism. I think it is going to be a really great information for screening as well.
Have you come across any data regarding the occurrence of acute pancreatitis in high triglyceride level patients?
For those who have hypertriglyceridemic acute pancreatitis, their triglyceride level is much more higher. As far as it's like more than 11 millimole per liter, so it's really high, much higher. And in some of the cases, they excluded that high among above 10 millimole per liter.
Okay, thank you very much. Congratulations for a very nice presentation.
Thank you.